since this conference was delayed, but actually it gave an opportunity to also highlight major, essentially gastroesophageal abstracts that were presented at ESMO, and I think it was difficult to ignore sharing kind of the results from those abstracts. And then really appreciate being within a STEAM company and other speakers. Dr. Grothy is definitely big shoes to follow, but again, very privileged to be involved in sharing these recent highlights. So my disclosures we've already covered. So in terms of a bird's eye overview of major abstracts, we'll look at anti-HER2 therapy in the neoadjuvant setting for esophageal and GE junction cancer, the RTOG 1010 trial. That was at ASCO. And actually, there's already been a lot of discussion with Trastuzumab Deruxtecan or T-DXd. This was also a major abstract of Destiny Gastric 01 trial, and actually some updated data from ESMO. And then actually, essentially, there was a large bolus, I would call it, of looking at immuno-oncology strategies for both non-metastatic and metastatic gastroesophageal cancers, which, again, is very unprecedented, at least in terms of my career in the past 10 years, all in one presidential symposium in terms of positive study outcomes. So getting right into the RTOG 1010 trial, this was a U.S. cooperative group trial, now known as NRG, in which patients with esophageal adenocarcinoma or GE junction, mostly CWORT 1 and 2, those patients in which you would identify for neoadjuvant cross approach chemoradiation with weekly carbotaxol. That was the control arm of this study, and typically a standard dose of radiation in North America and the US of 50.4 grays. But then the experimental arm for this study was actually, all patients were selected to have HER2 overexpression by standard IHC and FISH testing criteria. And those who screened positive for the HER2 biomarker, they were actually randomized to the potential for the addition of neoadjuvant trastuzumab with their chemoradiation. And actually, after surgery, patients went on to another year or so of trastuzumab therapy, essentially extrapolating from what's utilized in breast cancer. So in terms of the baseline characteristics, they were fairly well balanced in both arms. Modest phase 3 study, but essentially that was what was needed to be done to screen the requisite population of HER2 overexpressing cases. Not surprisingly, most patients were advanced T3 disease, essentially appropriate for trimodality therapy, and most patients had node positivity. So in terms of at least one of the major outcomes, pathologic response, given there's a lot of data, retrospective data sets that patients who achieve complete pathological response after neoadjuvant chemoradiation and go on to surgery, you see both arms essentially were well balanced in terms of those patients going to surgery, over 80% of the trial population. But then when you look at the pathologic complete response rates, actually disappointingly, you don't see any difference with addition of trastuzumab, even though this is, again, an enriched HER2 overexpressing GE junction esophageal adenocarcinoma population. And then looking at major study endpoints, disease-free and overall survival, I think it's pretty apparent from the Kaplan-Meier survival curves and the hazard ratios being 1 for both outcomes. Unfortunately, this was a negative study, despite, again, looking for HER2 overexpression. So I think, a lot of questions, of course, to be abound, and hopefully we can learn from this. But I think what we are increasingly recognized initially in the metastatic setting, and now really this appears to also be impacting the early stage disease setting, is this intratumoral heterogeneity of HER2 overexpression, which since initial scoring criteria for HER2 was developed, we are recognizing that there is essentially a high degree of heterogeneity in terms of the degree of the tumor that has HER2 overexpression. We're recognizing that there's actually multiple clonal populations, actually many tumor types we're recognizing as this being an issue. So not surprisingly, if you have a tumor in which it's homogeneous in terms of HER2 overexpression and you apply a HER2 target agent, there's much more greater number of clones being hit by a HER2 targeted strategy. And then subsequently those strategy, certainly you still apply it to hit the HER2 clone, but those tumors are heterogeneous, have other co-driver alterations. Likely you're essentially creating adaptive resistance as these HER2 negative clones outgrow the anti-HER2 strategy. We're also recognizing essentially interpatient heterogeneity, that even though this is a quote unquote a HER2 positive population, there is actually a lot of genomic heterogeneity in terms of other co-alterations. On the left panel here, you see actually a data set out of Memorial Sloan Kettering, which they applied next generation sequencing with their institutional panel that there's a lot of other co-drivers that can coexist, such as EGFR. KRAS mutations can differ between HER2 populations. Also, cell cycling signaling components such as cyclin E1, CDK6. And actually, interestingly, these were both pre and post treatment biopsies. You can actually see proportion of cases in which there's loss of HER2. Well, this is something we now are recognizing much more. And actually, this is very apparent even when you do circulating tumor cell DNA. So at least in this phase 2 study out of a Korean cohort of patients given lapatinib HER2 tyrosine kinase inhibitor, you can actually have cases in which HER2, represented by the yellow here, is actually still retained, but then there's actually co-driver alterations that which are arising, which putatively predict for resistance, such as FGFR2 and cyclin E1 amplification. But then there's also cases in which the Garden ctDNA, you can see that HER2, again represented in yellow, remains lost at progression. But then again, there's other co-driver alterations. So really, in terms of subsequent data sets and application of anti-HER2 strategies, we of course know in the metastatic setting that unfortunately a lot of agents such as TDM1, second-line lapatinib, these phase 3 trials were negative. We really need to, if we're going to continue to apply HER2-directed strategies, really still ensure that there's the target being present. So thankfully, Dr. Grothy actually covered T-DXd a lot. I won't belabor the point too much more in terms of its novel agent having a higher antibody-drug ratio and payload and a cleavable linker. But actually, what I will add is that, interestingly, in preclinical models, in terms of intratumoral heterogeneity, these are co-culture experiments in which there's HER2 positive N87 gastric cancer cells and actually co-culture with HER2 negative breast cancer cells, is that as opposed to TDM1, in which it's a not a cleavable linker, drug linker, in which there's no cellular death in terms of HER2 negative co-culture cells. But at least when you give DS8201A or T-DXd, actually both HER2 positive and HER2 negative populations are actually affected. So in parallel to the colorectal studies that were recently presented in gastric, there was also a major a study being performed, the Gastric01 trial. And actually, this trial was predominantly in Asia, Japan, and Korea in terms of enrollment. But the major cohort was a randomized, actually, study arm of patients who've at least progressed on 2 lines of therapy, and actually a good proportion of patients even had 3 or even 4 prior lines of therapy. But in this randomized signal-finding phase 2 study, it was 2-to-1 in terms of T-DXd. And actually, I will point out that the dosing of T-DXd of 6.4 milligrams per kilogram, because of concerns, again, of higher intratumoral heterogeneity of HER2 overexpression compared to breast cancer, is actually higher than the current FDA-approved dosing that those of you who treat breast cancer may prescribe at this point. And then actually the control arm in the randomized cohort was a physician's choice of actually irinotecan or paclitaxel, but given actually most of the patients had paclitaxel therapy, a good proportion actually received irinotecan. So essentially you're in a way comparing one topo 1 inhibitor to another topo 1 inhibitor. And actually we're also exploratory cohorts looking at HER2 normal or HER2 low overexpressing cases. So in terms of the baseline characteristics, I'll just point out that these, again, were all cases known to be HER2 overexpressing. Not surprisingly, all received anti-HER2 therapy as a requirement for study entry. But in terms of subsequent lines of therapy, a good proportion, again, had even 3 or 4 prior lines of therapy. And actually, a third of the patients had immune checkpoint inhibitors given regulatory approval of nivolumab in the third-line setting for all comers in Japan. But then looking at major clinical outcomes, looking at response rates, this actually was a positive study in terms of seeing much greater degree of responses. Initially, it was reported out as 51%, but actually confirmed overall response rates by independent central review was 43%. But this was still much better than historical controls, essentially of irinotecan or paclitaxel, being only 12.5%. There was even a proportion of patients with complete responses. And actually, you do see some durability of responses, which is also very encouraging, at least for our patients. Median duration of response was 11.3 months with giving T-DXd. And then subsequently looking at progression-free and overall survival, as opposed to a large proportion of patients receiving either irinotecan or paclitaxel, unfortunately progressing by 6 months' time. There, you do see at least at 12 months, a third of patients who receive T-DXd still being free of progression, still being alive of their disease. This translates to median duration or median progression-free survival of 5.6 months versus only 3.5 months with physician's choice of therapy. And this also translates to improved overall survival. This was 12.5 months median overall survival for T-DXd. Hazard ratio was zero point 0.6, essentially 40% reduction. And as such, actually, T-DXd has garnered regulatory approval for third line and beyond therapy in Japan as a result of this study results. Dr. Grothy actually very well covered the toxicities with T-DXd. And actually, given the Destiny Gastric 01 cohort had a randomization, we actually can even compare in many ways that this agent, even though it's an antibody drug conjugate, I think there is a learning curve, so to speak, in terms of toxicities. Even though major toxicities were at least grade 3 or 4, still numerically higher, but not proportionally much greater. But then you do see a lot of grade 1 and 2 toxicities being greater with T-DXd versus irinotecan, essentially active, chemotherapy. So I think, a lot of antiemetics, in my experience, has to be given. Currently, we're involved in an ongoing T-DXd trial in the U.S. And then also, as mentioned by Dr. Grothy, likely due to HER2 expression within the lung, interstitial lung disease is actually also a toxicity which needs to be monitored for. So at least with the Destiny Gastric 01 cohort of patients, there were thankfully no grade 5 events, treatment-related deaths, though there were still at least some up to grade 4 interstitial lung disease, and actually majority of the cases were able to resolve, though it did take some time for resolution, as well as interventions such as steroids, and of course holding a study drug for this for patients who experience this. But then actually at ESMO, there was actually interesting data presented for the exploratory cohorts, non-randomized, but those essentially, typically defined as being HER2 non-overexpressing, but still having some degree of protein overexpression, so IHC2 plus, and then FISH negative, or actually even an IHC1 plus cohort. And actually, you do see that there seems to be some signal here with the waterfall plots, and actually, at least confirmed overall response rate was 26%. This translated to a median overall survival of actually 7.8 months for those patients with 2 plus IHC. And then actually even the 1 plus cohort, there was about 10% confirmed overall response rate. And this translates to a median overall survival of 8.5 months. But I think one thing to make note is that actually the HER2 overexpression being defined here was based on archival tissue. There wasn't any mandate for fresh biopsies for any of the study cohorts. And of course, for the exploratory cohorts, these were patients that did not receive prior HER2 therapy. But I think there is a signal that which could be built upon. But again, in terms of that issue of spatial heterogeneity, intrapatient heterogeneity, and temporal heterogeneity, really we need to look at that even further. So thankfully, there is some blood in which they've collected, and hopefully they'll perform some exploratory biomarker correlatives to better define this temporal heterogeneity. So just to at least summarize this initial kind of foray into the HER2 directed abstracts, I think at this point for early stage disease, unfortunately, HER2 is an inactionable biomarker. Certainly it can be checked for interest, but I don't think it's currently indicated to give any HER2-directed therapy, especially in the neoadjuvant chemoradiation setting. In terms of Trastuzumab Deruxtecan, certainly it's very encouraging as a third-line agent at this point. In terms of whether or not this applies to Western patients to the same degree, I mean, we actually know from many cross-trial comparisons of studies that look at patients enrolled in Asia versus outside of Asia, patients enrolled in Asia actually have better prognosis overall, go through more lines of therapy. So I wouldn't be surprised if there is activity of T-DXd in US patients, so to speak, but in terms of whether it'll be the same degree of response and overall survival, I think it remains to be seen. And then again, as I mentioned, HER2 low cohorts, so to speak, has encouraging activity, though in terms of, again, patients not receiving prior HER2 therapy, in a sense, this raises an interesting biologic and clinical question. Are you subsequently actually, maybe you missed those HER2 overexpressing clones at initial diagnosis, and then those HER2 overexpressing clones grew out, and hence you're seeing the activity of T-DXd in this study population. Again, I think further with at least ctDNA, we can hopefully try and address some of those questions. So then now jumping into, again, the bolus of IO abstracts. So actually what's interesting is in terms of giving PD-1 inhibitors in the non-metastatic setting. The Checkmate 577 trial actually was reported as being positive at ESMO. Essentially, this was a phase 3 study for patients, again, with either actually squamous cell or adenocarcinoma histology, esophageal cancer, and CWER 1 to 2 GE junction. Again, appropriate for cross chemoradiation, though actually any chemotherapy backbone of chemoradiation was deemed appropriate for study entry. But specifically, those patients in which they did not achieve complete pathologic response, because again, at least for those who do achieve a complete pathologic response to chemoradiation, their prognosis is much more favorable. So this was actually trying to select for a poor prognosis population in which there has been growing literature that actually upregulation of immune checkpoints may predict for resistance to chemoradiation therapy. And as such, because of this, these patients were randomized in a 2-to-1 fashion to adjuvant nivolumab after surgery. Initially, it was a kind of 2-week dosing for the first 16 weeks, and then subsequently monthly dosing for up to a year, or a placebo control, given essentially with the cross trial, there's no adjuvant therapy, so to speak. This was really still the reference standard. And actually, for the endpoint of the study, it was a disease-free survival endpoint to at least be deemed acceptable as being a surrogate for overall survival, though secondary endpoints were overall survival as well. Though this initial reporting was mainly on the disease-free survival endpoint with a median duration of follow-up about 24 months at this initial data cutoff. So in terms of baseline characteristics for the Checkmate 577 trial, this was, this did have patients in Asia enrolled, but predominantly this was patients who are Caucasian, essentially in line with also practice outside of Asia with, again, neoadjuvant chemoradiation. For both squamous cell and adenocarcinoma histologies. This was predominantly an adenocarcinoma trial. This actually in many ways mirrors what was the study population in the cross trial. And again, a good proportion of patients had positive lymph nodes at surgical resection, again, a poor prognosis population. And then actually one thing just to point out, a recurring theme we'll see here in these abstracts is in terms of PD-L1 expression, this was a tumor proportion score or TPS PD-L1 measurement because it only looked at PD-L1 in tumor cells, did not look at immune cells, which again differs from current FDA-approved at least third-line therapy in the U.S., the combined positive score, in which you're also looking at PD-L1 expression in immune cells. But when you're only looking at PD-L1 in tumor cells, even with a 1% cutoff, this is actually still the minority of cases which demonstrate tumor positivity, so to speak, when only looking at tumor cells. So in terms of the primary endpoint, disease-free survival, this study without a doubt was positive, though it's very interesting. The curves were initially together up to 6 months. So there is still a study population which has very aggressive disease biology and poor prognosis in which nivolumab does not appear to make a difference. But then subsequently after 6 months, longer term follow-up, you do see a very nice separation of the Kaplan-Meier curves. There's no crossing of the curve, so to speak. So proportional hazards assumptions are being maintained. But the hazard ratio was 0.69 in favor of giving adjuvant nivolumab. This translates a doubling of the median disease-free survival from 11 months to 22.4 months. And actually, I think the median disease-free survival 11 months really, again, speaks to the poor prognosis of a study population. Now we have prospective data in the sense of those patients who don't achieve pathologic complete response to neoadjuvant chemoradiation. And this, of course, was statistically significant in terms of its pre-planned statistical analyses. And in terms of subgroup analyses, for the most part, when you look at the forest plot, all subgroups show benefit from adjuvant nivolumab therapy after trimodality treatment, though in some ways it does seem maybe squamous cell carcinomas, because of their disease biology, have greater degree of benefit from utilizing adjuvant nivolumab therapy. And actually, tumor cell PD-L1 expression really is a poor predictive biomarker, the TPS score. And actually, in a sense, we don't use that in gastroesophageal cancers. But this was at least the biomarker data that was available for this study reporting. And in terms of toxicities, thankfully, no really new safety signals in terms of giving single agent PD-1 inhibitor with nivolumab. I mean, not surprisingly, there was still a greater degree of immune-related adverse events with giving nivolumab therapy versus placebo, but at least majority of them were grade 1 to 2 in nature, no major difference in grade 3 to 4 events. So then switching gears now to the metastatic setting, for first-line treatment of gastric cancer. The Checkmate 649 trial was also presented at ESMO. This was a very large study of adenocarcinoma histology specifically, but then either gastric or G junction or esophageal in terms of primary tumor location, and at least in a sense, HER2 negative patients not known to be HER2 positive, given of course HER2 positive patients should receive trastuzumab with chemotherapy. This was a global study, but there was stratification for Asian versus US, Canada, and remainder of the world enrollment. And actually chemotherapy at backbone, which was the control arm of platinum fluoropyrimidine, though physician's choice of Zelox or Folfox, this was a stratification factor. But then patients, at least in the major second arm being presented here, were given open label nivolumab to added on to their first line chemotherapy. There actually was a previous third arm of nivolumab plus ipilimumab, but that arm actually was closed early because of early mortality. And this, at least results from this arm, still remains to be reported. But actually getting into the statistics, this will actually be also a recurring theme in the remaining abstracts due to multiplicity testing, looking at multiple endpoints being examined. You actually have to share the alpha to ensure statistical significance. So this was essentially looking at first at two primary endpoints of progression-free survival, but then actually looking at CPS scoring in terms of PD-L1 expression at a value of at least 5, that being either tumor cells or immune cells or a combination out of 100 tumor cells demonstrating PD-L1 expression. And then overall survival, again, was also a primary endpoint being looked at. But then if these primary endpoints were met at the level of significance predefined, then actually the alpha was passed on to enable subsequent overall survival analyses in actually all patients for this study, given PD-L1 expression was not a criteria for enrollment. And then subsequently, there actually will again be later data with nivolumab, ipilimumab, even though that arm was closed early. So in terms of baseline characteristics, looking specifically at the primary endpoint population of CPS greater than or equal to 5, this was well balanced. There actually was a cap on enrollment from Asian countries, again, because of prognosis appearing to be better in general in major randomized studies compared to non-Asian country enrollment. Not surprisingly, majority of patients were gastric cancer, though you do have a smattering of GE junction and esophageal adenocarcinomas. Of course, vast majority of patients had metastatic disease. And then actually, getting to MSI status that Dr. Grothe has, covered very well with colorectal cancer, there actually at least was some capturing of patients, though I think also the very low proportion, 3 to 4%, is reflective actually, in my experience, in terms of patients who are MSI high and essentially real world experience as well. So in terms of overall survival for PD-L1 CPS greater than or equal to 5, you see very nice separation of the curves, no crossing of the curves. This translates to improvement at 1 year of 46% with just chemotherapy to 57% with the addition of nivolumab, hazard ratio of 0.71. This did achieve its predefined p-value for significance. Median overall survival was 14.4 months, breaking the 1 year ceiling, so to speak, for metastatic disease. And then actually, subsequently, they were able to analyze the CPS greater than 1 population, as well as all randomized patients. And interestingly, you do see still a positive study outcome, so to speak, at least in all comers. Though, in a sense, the hazard ratio, interestingly, is diluted in a sense, as opposed to being 0.71 before. Now it's 0.77 with just CPS 1 patients. And then actually, if you also include the CPS 0 patients, now you're actually looking at very large numbers, about 1,500 patients now. Still a positive statistical study endpoint, so to speak, at least median survival of 13.8 months with addition of nivolumab. But again, the hazard ratio now is down to 0.8 in terms of relative risk reduction. And actually, one other thing I'd like to point out is that, interestingly, with CPS 5 being defined here, this was with the 28-8 antibody that actually BMS utilizes for their assay or PD-L1 overexpression. About 60% of the patients were CPS 5 or above out of the overall study population. So in terms of at least the other major endpoint that they had predefined power to study was progression-free survival. So you do see for CPS greater than or equal to 5, hazard ratio of 0.68, statistically significant, continued separation of the curves, with adding nivolumab being more likely to be free of progression, as well as being alive of disease with addition of nivolumab therapy. But actually, they did not have the statistical power to really look at the CPS1 population, all randomized patients with progression-free survival, even though numerically you do see there is also favoring of progression, being free of progression with adding the nivolumab therapy to chemotherapy. In terms of subgroup analyses, essentially all subgroups in the forest plots showing benefit from adding nivolumab therapy, and this is specifically looking in the CPS5 patients. But then I think what is interesting, at least when you have a denominator of at least counting a certain number of at least immune cells, those in which actually they did have tumor cell PD-L1 expression do seem to benefit a bit more from adding nivolumab therapy. But then also getting to MSI high status, these are patients who get FOLFOX plus nivolumab. They're very dramatic in terms of small numbers, though, but still very dramatic in terms of median overall survival not being reached versus only 8.8 months if they only received chemotherapy without PD-1 inhibitor in frontline settings. So I think really this argues that patients with MSI high disease should get PD-1 therapy as soon as possible in their treatment course. And then lastly, in terms of response rates, you do see, at least for the CPS5 population, increases in responses up to 60% in terms of major tumor reduction by RECIST for addition of nivolumab to FOLFOX chemotherapy. And then durability responses, there does appear to be a tail to the curve. This at least was median of 9.5 months, though it is very compelling to see at least at 1 year, over 40% of patients being free of progression, being maintained in response for those who achieve response to initial, again, chemotherapy plus nivolumab. And then at least with adverse events, I'll briefly cover that for the most part, no new safety signals seen in terms of immune checkpoint inhibitor toxicities, which we expect at this point. Many of us are familiar with all the major tumor types for which there's approvals, but I still think at least with combining with chemotherapy and gastroesophageal cancer, there was higher number of treatment-related adverse events that led to discontinuation. So there is somewhat of a learning curve. I think that we still need to be mindful of these patients. That's not a free ride when you add a checkpoint inhibitor to chemotherapy, and there was even a greater degree of treatment-related deaths with this study population. And certainly it'll be of interest to see the final manuscript, which is yet to be published in terms of, again, the major toxicities. But then looking at another major data set, incorporating a PD-1 inhibitor for first-line disease, this was the Attraction-4 study, also at ESMO, but this was actually only patients enrolled in Japan, Korea, and Taiwan, essentially looking at a chemotherapy backbone, but there was placebo control in terms of adding nivolumab as an active comparator. And of course, the chemotherapy backbone differs a bit. They have S1 available as a floor permitting in Asia versus we did not have that in the US and other non-Asian countries. But actually, this was all comers, even though tumor cell, again, TPS was a stratification factor. But in terms of the endpoints, it was progression-free and overall survival, but not defined by PD-L1 CPS enrichment. Again, hierarchical or multiplicity testing, looking first at progression-free survival, but even if progression-free survival endpoint was not met, there was a stricter alpha to look at overall survival still as another major primary endpoint. So in baseline characteristics for this predominantly Asian or exclusively Asian study, majority of patients from Japan, and interestingly, well, I think in a sense because of screening available being in Japan and Korea, at least there was even a fair proportion, a third of patients having limited metastatic disease at their time of, I guess, study entry and as well as diagnosis. They did again look at tumor cell PD-L1 expression, but again, by the TPS, you see it's still a minority, less than 20% of patients are defined as PD-L1 positive. You only look at TPS, and most patients received S1 plus oxaliplatin chemotherapy. So in progression, in terms of primary endpoint progression-free survival, The study did meet its endpoint actually at interim analysis almost 2 years ago now at data cutoff. You do see very nice separation of the KM curves with adding nivolumab, such as at 1 year, 45% of patients were free of progression. With the addition of nivolumab therapy, this translated actually to, in many ways, very favorable numbers. Even the control arm did fairly well, 8.3 months, again, not uncommon with an Asian gastric cancer metastatic study. But this hazard ratio, 0.68, was significant. But what's interesting when you look at the overall survival outcomes, again, both arms did very well, 17 months. Again, contrast with this, the 14-month median overall survival from the Checkmate 649 trial. But hazard ratio was 0.9, crossed one, was not statistically significant. So I think essentially several takeaways is that with a PD-L1 CPS non-selected population, maybe you are diluting your benefit with adding nivolumab to frontline chemotherapy. And there actually was some more cutoff, actually more crossover in terms of patients receiving adjuvant subsequent PD-1 inhibitors. But then really, if you go back to the Checkmate 649 trial in terms of their subset analysis of Asian patients, I mean, there may be something different with the Asian patients here versus, the Attraction 4 trial. I still think that CPS selection really does appear to play a major role here. So again, in terms of subgroup analyses, for the most part, no major differences. Though interestingly, those patients with had limited organ metastases actually had very favorable median overall survival. This at least speaks to maybe tumor burden playing a role in terms of success with immunotherapy strategies, maybe delayed immune responses. And again, tumor PD-L1 TPS is a very poor predictive biomarker to distinguish benefit from nivolumab therapy. And again, the Traction 4 study unfortunately did not look at CPS. It remains to be seen if they'll look at CPS as a correlative predictive biomarker. Um, so then lastly, getting into, again, the metastatic setting, the KEYNOTE-590 trial also presented at ESMO, but this was esophageal cancer, but both adenocarcinoma, but at least those in which they were not, any significant overlap, even though it included GE junction. It tried to limit to patients that were CR1, so high up in the GE junction. And this trial also included squamous cell histology, which of course is the other major histology for esophageal cancers. Again, these were patients newly diagnosed without any treatment, at least having measurable disease for many of the study outcomes. This was a global study, but Asian versus non-Asian enrollment was a stratification factor, as well as stratification for histology, which certainly would be necessary. This had a backbone of high dose cisplatin and 5-FU chemotherapy, deemed more of a global standard as first line therapy. Placebo-controlled 2 addition of pembrolizumab in the experimental arm, 1-to-1 randomization. Again, multiplicity testing, looking at multiple endpoints, looking for a signal, as such shared alpha, much stricter in terms of statistical significance being met, but they at least looked at progression-free survival for esophageal squamous cell carcinoma specifically, and then actually looking at those in which PD-L1 expression, again, by the combined positive score CPS criterion greater than 10, and actually, well, if that was met, they can actually look at overall survival for the all squamous cell carcinomas, and then subsequently, as long as these initial predefined statistics were met, then the alpha could be passed on to look at subsequent other subpopulations. So in terms of baseline characteristics for this KEYNOTE 590 study, about 700 patients, half the patients were actually from Asia. There wasn't necessarily a major cap in enrollment, but there was at least still representation from patients enrolled outside of Asia. Of course, all patients or predominant patients had metastatic disease, and actually 3/4 of patients were squamous cell histology in this study. And actually, interestingly enough, even though this was not a selection criteria for the study, about half the patients had high relatively high PD-L1 expression, again by CPS being a score greater than or equal to 10. And then looking at the one of the major endpoints, esophageal squamous cell carcinomas, CPS greater than or equal to 10. I think it's pretty clear in terms of improved overall survival with adding pembrolizumab to frontline chemotherapy. Hazard ratio 0.57, definitely met its predefined statistical cutoff. This translated to very encouraging doubling of 2-year survival from 15 to 31%. Median was 8.8 months, improved to 13.9 months. And then as a result, they were also able to look at the overall squamous cell histology population, regardless of PD-L1 status. Essentially, you added about another 130 patients to both arms that had CPS less than 10. But this still remains significant, though there again is some dilution of the hazard ratio, 0.72, though this still remains significant. And at least the 2-year overall survival rates still appear to be very beneficial, 29% for those patients who receive pembrolizumab with their frontline chemotherapy. And then looking at both histologies combined, but still cutting off at CPS greater than or equal to 10, you do see that this remained, again, significant in favor of adding pembrolizumab therapy, the backbone of chemotherapy. 2-year survival, again, about 31%. But again, recall that 3/4 of the patients are squamous cell histology. But I think there is at least an adenocarcinoma histology population in which, if you at least properly select for those patients that have high upregulation of immune checkpoints, they will likely benefit from addition of a PD-1 inhibitor. And then looking at all patients, again, hazard ratio now being 0.73, but still remains significant. At least this is of interest that you are seeing improved outcomes. Though an argument can be made: is this mainly being driven by those patients that are CPS 10 and squamous cell histology? And then in terms of progression-free survival, for all esophageal squamous cell carcinoma patients, you are at least benefiting your patients. The very nice separation at the major, essentially imaging time points. I mean, you unfortunately do see major drop-offs still when patients get imaged, when you have, looking at measurable disease, but at least 1 year, the PFS rates are doubled with addition of pembrolizumab with all comers. And then actually that degree of benefit, again, is magnified, especially with later follow-up for those in which the CPS was greater than 10, whether or not they're adenocarcinoma or squamous cell histology. And again, for all patients, there does appear to be a suggestion that adding pembrolizumab in frontline therapy is of benefit than just chemotherapy alone. In terms of major subgroup analyses, essentially all major subgroups in these forest plots are showing benefit, though there does seem to be at least a clearer signal with CPS greater than 10 versus less than 10. And then also, again, progression-free survival is the same here. And then lastly, response rates were improved with adding pembrolizumab to frontline chemotherapy, up to 45%. Durability responses were being maintained as well with pembrolizumab therapy. And then lastly, in terms of adverse events, not surprisingly, more immune-mediated adverse events, though, again, I think a slight learning curve in terms of adapting frontline pembrolizumab to chemotherapy. So in terms of some takeaways, I think we are actually now finally in the era of IO therapy for gastroesophageal cancer, though I think patient selection is still very key. Squamous cell carcinomas in the frontline setting, and definitely feel more confident in terms of adding PD-1 inhibitor to chemotherapy if their CPS is 10 or above. And at least for adenocarcinomas, those in which the CPS is 5 or above should really be the ones in which at this point, and of course MSI high patients should have frontline nivolumab with their chemotherapy. And I think, though, that at least in terms of biomarker testing and approval, there may be some differences in characteristics of the 28-8 and 22C3 assays. Will need more data. But then at this point, PD-L1 definitely is at least giving us a signal of immunogenicity. But I think further research will hopefully better define molecular biomarkers and, of course, looking at ways to overcome resistance. And with that, I appreciate everyone's time. I think we can go to questions.
Yep, thank you, Dr. Chao. So we